minutes. So I will just flip through a lot of things because none of the PGs are here at 9 o'clock. So that is sad actually. None of the PGs are here, senior most people are here. So I will just go through the slides. This FFA has some interesting history. It started way back in 1959 with Novotny and Alvis. And over all these years, there has been no change in FFA, starting from dye, pictures, some little changes in making it digitalized, the film became digital, and that is the only thing, and little wide field. So there is no change over the last many years, and mind you, this was the article that was rejected by American Journal way back in 1959 saying that this is a useless procedure. Okay, so fluorescence is something when you excite with the blue wavelength, the electrons go to the higher orbit, and when they come back, they emit. So that is the excitation and emission, and this is called fluorescence. And this is a dye, sodium fluorescein dye, which is 80% protein bound and 20% free. So it has got a blue absorption and emission of green. You can there are one or two things. Blood retinal barrier, you have to be very careful. I mean, you should know what is blood retinal barrier. The retinal pigment epithelium is impermeable. Choroidal vascular network is freely permeable, and retinal vasculature is impermeable unless there is a loss of pericyte. So since this is mainly 20% is free, it will leak from choroidal vessels. So choroidal vessels you will not be able to see properly, and will be blocked by retinal pigment epithelium. So this is basically the principle. The procedure I am not going into the details. Just make sure that you put a cannula and don't do in the butterfly. So that is one thing that we have learned with experience. You have to take a color photograph. You have to take a red free and dye. Once you start the dye, initial picture should be very fast because there is once the arm to retina time is over, the next phases like choroidal filling, arterial phase, venous phase, everything comes very fast except the recirculation phase. So you have to take it very fast. So these are the phases of normal FFA: pre-arterial or choroidal phase, arterial, arteriovenous, venous, late phase. So pre-arterial phase is like this. You can see within few seconds, within 8 seconds, you will see the choroidal patchy filling. You will not get a very clear picture of the choroidal vessels because 20% of the dye is leaking through the choroidal vessels. But at that time, you can see the cilioretinal vessel also, which is filling from the choroidal side. So this is choroidal phase. Now comes the arterial phase, retinal artery. So this is the beginning of that arm to retina. This is the end of arm to retina time. Usually it is 8 seconds and 8 to 12 seconds. So if it is delayed, there could be different reasons. If your vein has blocked or has a spasm, it will not reach the eye. So immediately take it to the other eye and see whether other eye also is not coming. So if it is a delayed more than 30 seconds, there is a delay in arm to retina time, which is usually seen in venous stasis retinopathy. So this is arteriovenous phase, both arteries and veins, and then venous phase predominantly, and then late phase, recirculation phase. So normal macula is dark because of synovial pigment already in the retinal pigment epithelium. So you will not get a background choroidal fluorescence. Okay. Normal optic disc is early it is hypo, later it is hyper due to the staining of the peripapillary capillary network. Okay. There are different adverse events. What we see is mild itching, allergy, nausea, vomiting, all this stuff. So we tell the patient not to take anything for 2 hours at least. They don't want to spoil the angiogram room. Extravasation can happen once in a while. And these are the 4 types of fluorescence, abnormal fluorescence: hyper, hypo, auto, and pseudo. Pseudo, forget it. Nowadays it doesn't come. Autofluorescence also, there are other. I will go through each one of these. So hyperfluorescence is increased abnormal fluorescence. You can have in window defects, leakage, pooling, and staining. Okay. So what is window defect? This is very clear picture of window defect. There is no RP. So you can see the choroidal vessels without any blockage of RP usually blocks the fluorescence. So the arterial phase itself, you can see very hyper fluorescent rip. It is a RP rip. So you can see that area. So next is leakage. The leakage theoretically it is hyperfluorescence increasing in intensity in the late phase. So this is a leakage. You can see a small hyperfluorescent area in the lower part, which is a new vessel. It is increasing in intensity and size. So that is leakage due to new vessels. Okay, this is multiple leakages all around the mid periphery due to. And in this case, another point is there is a lot of asteroid, but you can see the fluorescence very clearly. So that is an advantage of fluorescein angiogram in asteroid hyalosis. Okay. So this is another case of new vessels leaking profusely. And this is a choroidal neovascular membrane at the macula. There's a network of vessels in the central area. In the late phase, it is increasing in size and margins are becoming fuzzy. So it's a leakage. Now, what is pooling? The size and the margins does not become, it is collection of dye in a space, localized space. So here you can see 3 lesions. All lesions are increasing in intensity, but the size is remaining same, no pooling, and no margins are normal. So that is a pooling of dye in pigment biliary detachment. While this has multiple pigment biliary detachments, and the central area has a central area has a smokestack leak. Okay, so this is another case where there is a increase in intensity and margins become fuzzy. It's a in-blocked leak, and here there is a smokestack leak. So these are all examples. One thing that I forgot to tell is, whenever you present an angiogram, you should have a color photo early, mid, and late. Then only you can interpret properly. So this is another case where there is pooling of dye in subretinal spaces due to leakage. This pooling of dye inside. Now staining is leakage of dye into a tissue. So the margins will not become very fuzzy. Okay, so that is staining. So these are some of the conclusions. Okay. Now going to hypofluorescence, it is 2 things are there. One is blocked fluorescence and the vascular filling defect. So blocked fluorescence can be anything in the vitreous, retina, subretinal, anything. So if it is a vitreous hemorrhage, it will block both retinal and choroidal fluorescence. If it is subretinal hemorrhage, it will block only choroidal fluorescence, not the retinal fluorescence. So filling defect, how will you differentiate? Filling defects are, you have to compare with this is filling defect or hemorrhage, I am not sure because I don't have a color photo. While this is definitely a filling defect because there is no blocked material in that area. This is another filling defect. So this is hypofluorescence. So pseudofluorescence is due to filter mismatch, which does not see nowadays, which we don't see. Autofluorescence is also there, but that is seen in drusen and other things. Wide field fluorescent angiography has changed the attitude, outlook in the last few years. We used to take only picture of the central area, but the peripheral new vessels can be missed. So wide field angiogram shows something called predominantly peripheral lesions that could be a vision threatening problem in diabetic retinopathy. So these are all wide field, the central area and wide field. So we nowadays we don't miss anything in the periphery. That is the only change that has happened in the last many years. So wide field angiogram has changed the. So limitations are, problems are there, where there is a choroidal vascular details we are not seeing properly because it is it leaks from the choroidal vessels. And if there is a hemorrhage, it will block. Then came indocyanine angiography. There are some differences. While fluorescein is 80% protein bond, this is 98% protein bond. So it will remain inside the choroidal vessels. And here we are using infrared lights for stimulation and emission. So it is a longer wavelength light, so it can penetrate through hemorrhage also. So ICG is 98% bound to plasma proteins, and dye remains inside the fovea capillaries. That is why this is used for choroidal imaging. Adverse events are rare, but you can have contraindications in iodine allergy because the ICG has to be dissolved in aqueous sodium iodide solvent. So that is why here you are not very strict about the phases, but you need early phases very fast. That is the only problem. Initial video angiography is ideal because every second you need. So rapid serial photographs are required in the early phase of the study. So mid phase usually usually we use it for polypoidal choroidal vasculopathy. I will show some pictures. And late phase also is important. Hypofluorescence, again here also there is blocked fluorescence and vascular filling defect. But here there is a small difference. Suppose it is a thick nevus like this, it will be hypofluorescence. There is no term called senescence. Okay, that is not a term. A lot of people, even learned people, say senescence. There is no term in physics called senescence. So it is fluorescence only. So if it is a thick nevus, you will see hypofluorescence in early phase and late phase. While if the hemorrhage is thin, initially you may see something in the choroidal details, but later when the washout is there, you will see the contrast better. So that is the advantage of ICG. Through thin hemorrhages, you can see some details in the choroid. Inflammatory infiltration and capillary non-perfusion, like ischemic infarct in the choroid, can be made out very easily. So vascular filling defects and watershed zone. This is the watershed zone at the disc, which is normal. Bare sclera at the peripapillary area, you don't see anything. This is pseudofluorescence. Without any dye itself, you can see the hyperfluorescence. So feeder vessel, we used to try to get the feeder vessel for focal treatment. Nowadays we are not very strict about it. The main use of ICG is currently polyp. This is a bunch of polyps at the center. This is another bunch of polyps in the peripapillary region. This is another area in the peripapillary region. And this is at the notch, you can see a bunch of polyps. And this is multiple polyps. And in between, you can see a branching vascular network also. So these are Fluorescein, a ring of polyps. And this is pre-treatment and post-treatment. The only investigation that will show this beautiful after treatment whether there is a regression of polyp is ICG. And Whitefield ICG has helped in identifying peripheral polypoidal lesions like this, which we call it peripheral hemorrhagic exudative chorioretinopathy. So this is another branching vascular network in PCP. And the late geographic hyperfluorescence is seen in BVN. And choroidal CSCR also, we use this ICG to see the area of leakage which we use to treat with PDT. And the final conclusive, the most important use is in choroidal hemangioma. You can see this sort of blooming in the early phase ICG while nothing happens in fluorescein angiography. So this is the few uses of ICG. It is still being used, not many places are having it, but we have significant usage in many of this. Now final question for PG, which is FFA, which is ICG, because you will get somebody will show you, examiner will show you. If the disc is very dark, in the late phase it is ICG. Usually in FFA, you will get a staging of the disc vessel. So at least you understand this, I will be very happy. Thank you very much.